Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you. I'm an acting instructor here at the University of Washington. I'm a research associate at Fred Hutchinson Cancer Center. I'm also an affiliated faculty at the University of Cape Town. And I said earlier, but to call this a conference review is pretty inaccurate since I'm only going to be able to hit on a few items from the conference, but it was fun to pick a few that I thought would be interesting or practical or just good knowledge to share. No conflicts of interest or disclosures. This is just a disclaimer on the funding. This is essentially a disclaimer on the data considerations and limitations. And this is the agenda. I won't read through it since I'll hit on the titles when I go through it, but I picked 3. I had 4, but it was just too much for the time. So I'm first going to talk about initial evaluation of injectable cabotegravir or CAB law safety during pregnancy in the HPTN 084 open label extension. So as background, HPTN 084 is a phase 3 randomized double-blind, double dummy active controlled superiority trial that was done in 20 sites in 7 African countries. And it showed that long-acting injectable cabotegravir significantly reduced HIV acquisition compared to daily oral TDF-FTC in people who were assigned female at birth. However, during this randomized trial period, participants had to use long-acting reversible contraceptives, and anybody who had a positive pregnancy test had their CAB law held. So this left the question of the safety of CAB law during pregnancy. So this is a kind of a knowledge gap in general, and I have interest in trying to acquire some information to help inform us on how to handle CAB law and during pregnancy, since currently it's not indicated for people in that situation. HPTN 084 open label extension sought to evaluate the safety of CAB law during pregnancy. So I won't go into the detail too much on the methods and these abstract reviews in general, but as you can see on the left-hand side, so in the original study, people were randomized to either cabotegravir or TDF-FTC as their PrEP. So in the open label extension, eligible participants were offered the choice of either CAB law or TDF-FTC as their PrEP, and the prior contraceptive restrictions were removed. Pregnancies were tracked through periodic urine testing, and the pregnancies were categorized by the exposure group, essentially. So CAB law during pregnancy, CAB law before they got pregnant. So, for example, they were in the CAB law group, and then they chose to be in the TDF-FTC group, or people with no CAB law. So they were in the TDF-FTC group, and they decided to stay with the TDF-FTC. The study period, so the open label extension started in 2022 and went through the end of 2023. And the outcomes monitored were pregnancy incidents, maternal adverse events, or AEs, poor pregnancy outcomes, and infant outcomes. In terms of results, so almost 2,500 participants were enrolled in the open label extension, among whom there were 351 incident pregnancies among 334 participants over a little over 3,000 person years. In terms of maternal AEs, so you can see the table on the right-hand side. So in terms of any grade 2+ AE incidence rate, the rate was a little bit higher in the CAB law group, but the confidence intervals did overlap. And then when you look just at the pregnancy-related grade 2+ AEs incident rates, the rates are pretty similar and confidence intervals all overlap. So not clearly any significant difference. When we look at poor pregnancy outcomes, so if you look at the figure on the right here, the horizontal bars represent each of the different groups, CAB, prior CAB, or no CAB. And really the outcomes of interest in terms of poor pregnancy outcomes were the preterm birth, stillbirth, and spontaneous abortion. And essentially, all the rates fell within the background rates for the general population. And while there was some differences, this was basically all driven by spontaneous abortion rate differences. And I would say that you have to really interpret those rates with a lot of caution because elective abortions are illegal in most of these countries where this study was conducted. So often elective abortions are called spontaneous abortions. And then looking at infant outcomes. So on the left-hand side, you can see the different growth parameters that are evaluated. So head circumference, length, and weight, they're all similar in the different groups. And then looking on the right-hand side here, I highlighted a median gestational age at delivery and median birth weights. They're all similar in the different groups, no significant differences there. There were 4 neonatal deaths in the active CABLA group, which was also much bigger than the other 2 groups. None of them were considered associated. One was a major congenital anomaly that was not considered associated. And then there were 3 deaths due to respiratory distress. So in conclusion, maternal, pregnancy, and infant outcomes were similar across the non-randomized exposure groups and consistent with expected background rates. And CABLA was well tolerated in the pregnant women. The pregnancy-related AE rates were similar across the groups. So I would say that this provides initial data that's reassuring in terms of the use of CABLA during pregnancy, at least in populations where pregnancy and HIV incidence are high. This open label extension is ongoing. They're continuing to accumulate data which they'll evaluate and release in the future. Next, I'll talk about STI testing rates and STI positivity among PrEP users randomized to 3 or 6 monthly monitoring. Preliminary analysis of the EASY PrEP study in the Netherlands. So, as most of you know, probably standard of care for PrEP monitoring for STIs involves visits every 3 months. The concerns with having 3 monthly PrEP monitoring visits includes that it may be a burden on PrEP users, which may make them drop out of it. It may be unnecessarily costly. It may lead to overtreatment of STIs that could drive resistance. It may not impact STI prevalence. It's not really clear, and there's not a whole lot of data really supporting it one way or the other. So the EASY PrEP study sought to evaluate the impact of 6 versus 3 monthly PrEP STI monitoring on the number of clinic visits and STIs diagnosed. The population was men who have sex with men in 4 sites in the Netherlands. They were public health clinics. The design was randomized controlled trial on the non-inferiority of the 6 monthly versus 3 monthly PrEP monitoring. All participants were allowed free in between STI testing visits if they wanted. The study period was between September 2021 and March 2022. The outcomes that were looked at here, overall visit rate, in between STI test visit rate, and positive bacterial STI rate. They had some other outcomes that they're continuing to look at, but weren't ready for prime time at the time of the conference. So looking at results, there are almost 450 participants who were randomized 1-to-1 to either 3 monthly or 6 monthly scheduled testing, which contributed to a total of 560 person years of follow-up. Honestly, the key thing here is the left-hand figure. It's a bit of a no-brainer. Obviously, people who have scheduled visits every 6 months instead of 3 months are going to have less visits. But what it was trying to look at is, do people come in for more in-between visits, and does that sort of compensate for the less scheduled visits? And the answer is no. People overall have less visits, even though there is a bit of an increase in the in-between STI testing visits compared to if you have every 3 monthly visits, which I think is fairly intuitive. Now looking at STI positivity in 6 versus 3 monthly monitoring arms. So on the left-hand side, this is looking at STI positivity by monitoring frequency. So they're looking at gonorrhea, chlamydia, and syphilis. And essentially, there's no difference when you look at the positivity among all the visits between the 2 groups, or the scheduled or the in-between visits. One question is, okay, so people are probably going to come in for, if they have symptoms, they're probably going to come in for in-between visits if they don't have a scheduled visit. But what if they have asymptomatic infections, which obviously are not uncommon? Are we going to begin to miss those if we go to the more spaced out visits? And so that's the logic behind having this breakout on the right here, asymptomatic STI positivity by monitoring frequency. And so these were visits where the participants did not report any STI-related symptoms. And if you look at the overall aggregate all visits, there is a slight difference, a slight increase in the asymptomatic STI positivity in the people who had the more spaced out visits. The meaning of that, clinical significance of that, is not really totally clear though. So in conclusion, monitoring every 6 months versus every 3 months leads to more in-between STI testing, fewer scheduled PrEP monitoring visits, of course, and fewer overall visits. And then the overall STI positivity is similar in the 2 monitoring frequency groups. There's a slightly higher positivity of asymptomatic STIs in the 6 monthly arm, as I showed you. So 6 monthly monitoring as a standard of care may reduce healthcare costs and burden on PrEP users without resulting in major increases in STIs. And I will say the Dutch guidelines have already changed their advice. They now advise monitoring PrEP users every 6 months. And it's interesting because I think the jury's out a little bit. There's still a lot of questions in terms of the consequences of shifting to these visits. We do other things during these visits. But I think it's a good question to ask, since I'm not sure how much data really supported one versus the other to begin with. Now shifting to the last item. So twice yearly lenacapavir or daily oral emtricitabine tenofovir alafenamide for HIV prevention in cisgender women. Interim analysis results from the Purpose 1 study. And I'll just note that they call TDF-FTC FTDF or FTAF, just so not to confuse you. But since the figures use that, I'm going to just highlight that since I'm going to use that in this. So the background is essentially cisgender women account for about half of the 1.3 million new HIV infections that occur annually. Standard PrEP for cisgender women involves daily oral TDF-FTC or FTDF, which is effective as taken as directed. However, given poor women's uptake of it, poor adherence to it, and poor persistence in the use of it, oral PrEP really is a pretty limited impact worldwide, underscoring the need for new options. Lenacapavir is a novel first-in-class multi-stage HIV-1 capsid inhibitor, and it offers a novel long-acting option for twice-yearly subcutaneous injections to be used as PrEP. Well, the purpose of Purpose 1 study was to assess the efficacy of lenacapavir and FTDF in preventing HIV acquisition. So population were adolescent girls and young women from 28 states in South Africa and Uganda. Most of them were in South Africa. The design was a phase 3 double-blinded randomized controlled trial comparing twice yearly subcutaneous lenacapavir, daily oral FTAF, and daily oral FTDF, which was the active control. So they're essentially comparing the new injectable with the newer of the TDF combos, or the FTAF, versus the older FTDF. Since it's not ethical to do a placebo, the FTDF is the active control. The study period was August 2021 to August 2023. The study was stopped early. Outcomes were looked at were HIV incidence in each group, adherence to PrEP regimens, and safety profiles, including injection site reactions. I won't go into this in detail, but the trial design is interesting. So essentially, they initially screen all the individuals, and then people who are HIV positive. So people who are HIV negative, they then randomize to one of the three groups. And then people who are HIV positive, they then do further testing to try to assess the recency of the infection. And then using a consensus way of calculating this, they can estimate the background HIV resident incidence, which is important since you can't do placebos ethically. So they want, but this is useful in having something to compare to. So results, there were over 5,000 initially HIV negative participants randomized 2-1 to lenacapavir, FTAF, or FTDF. This first result, incidence of HIV infection, is pretty striking. So you can see the background incidence on the left, estimated background incidence, the two oral PrEP HIV incidence on the right two columns, and then 0 for lenacapavir. And that compares to 39 infections in the FTAF group, 16 infections during the FTF group. And if you look at the exposure, the person-year exposures, it's, the lenacapavir and the FTAF is about the same. Another way of looking at it is incidence of HIV infection. So this, on the left-hand side, this is incidence rate ratio comparing HIV incidence in lenacapavir and FTAF compared to background. And so further to the right means higher, incidence is higher than background. To the left is lower, and obviously the lenacapavir wins. And if you look on the right-hand side, this is now incidence ratio comparing HIV incidence in lenacapavir and FTAF groups with the incidence in FTDF group. And again, lenacapavir looks great, and the oral PrEP, again, does not look good. So in terms of adherence, when you have a twice-a-year injections, you don't have a lot of data points for assessing adherence in terms of lenacapavir, but there was 92% adherence for the duration of the study. And then adherence was much lower for the oral PrEP. You can see on the figure right-hand side. So there's the FTAF and then the FTF, and they did 10% of the people they basically took out and did blood spots and then assessed the amount of drug in the people and could extrapolate the doses they probably had been taking. And basically people aren't taking it and they get worse over time. People aren't taking it often and adherence gets worse and worse. And then in terms of safety, there were no significant safety concerns, although injection site reactions were more common in the lenacapavir group. Then the placebo injection groups, 4 participants in that group discontinued the regimen due to injection site reactions. So in conclusion, no participants receiving this twice yearly lenacapavir acquired HIV infection during the duration of the study. Obviously, the HIV incidence was significantly lower than the background or the incidence associated with the oral PrEP. Adherence was low in the oral PrEP for both of them, and there were no major safety concerns, although there was a higher rate of injection site reactions in the lenacapavir group. So in conclusion, really twice yearly lenacapavir offers a highly efficacious and discrete option for potentially improving PrEP use among cisgender women. Evaluations of the efficacy and safety in other populations and long-term, as well as real-world effectiveness, are ongoing. There's a Purpose 2 study that is ongoing in a different population. Summary takeaway points. HPTN 084 open label extension, which was done in sub-Saharan Africa, has provided reassuring data regarding the use of CABLA in pregnancy, at least among populations where pregnancy and HIV incidence are high. Easy PrEP study, which was done in the Netherlands, suggested that STI monitoring every 6 months instead of every 3 months as standard of care may, I guess this is a little overstated, it may be better, I would say, than every 3 months in terms of the burden on users, and may not result in major increase in STIs. And then the Purpose 1 study done in South Africa and Uganda provides, I think, pretty compelling evidence that the twice yearly lenacapavir offers a highly efficacious option to potentially improve PrEP use among cisgender women. Although I think there's a lot of caveats in terms of, we'll see how the real world efficacy works and access works.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.